schematically, and for those people who like to really see what you're looking at, there's the virus itself under electron microscopy. In magnified views, you can see these little spikes, which is why it gets the term corona, because it looks like a crown around the virus. And here it is inside respiratory cells, replicating and producing all of the problems that we know it can produce in certain people. Ontario, we had our first case actually in late January. And by the time the first case showed up in our public health unit at KFLA, there were already 1,000 total cases in Ontario. Our first case was on March 27th. And you can see since that time, there's just been a continual increase in the number of cases that have occurred both nationally in Canada and certainly provincially here in Ontario. Ontario and Quebec regrettably have led the way in terms of total numbers of cases. This is just a little map, a schematic to sort of show you what's been happening in Ontario. And you can see the rate of infection by color coding. Blue areas have very little activity, green a little bit more. And then of course, once you get into the pink and red, you see more. And this is just a magnified view here of southeastern Ontario. Leeds, Grenville, Lanark, unfortunately, has had a little bit more than us, the public health unit that's to the east of us. Although I'll tell you that most of that was occurring way up here in the northern parts of Leeds, Grenville, Lanark. And so a lot of those cases were going to Ottawa rather than us. We tend to take people sort of from the southern part of LGL. And Hastings, Prince Edward County has actually been very, very low activity, a total of 44 cases. And they have not actually had a case for almost 9 weeks now. Here in KFLA, this is from the dashboard that the public health unit puts out. These are new cases, and these are active cases over a period of time. So the x-axis here is time. And you can see this was our first wave of infection. We ended up totaling about 63 cases altogether. But since that time, of course, we had a very specific cluster outbreak that was related to a personal service industry here in Kingston, which resulted in numbers that were really quite close to what we saw with our first wave. This is not a second wave. This was a cluster outbreak. And I'm going to talk a little bit about second waves towards the end of my, my brief talk here today. So if you want to look at it, if you're a digital person, not an analog person, this is what it looks like in Ontario up till this last Monday. There were over 37,000, close to 38,000 cases. There have been about 1.8 or 1.9 million tests. About 12.2% of people were hospitalized. There were somewhere near to a little over 2,700 deaths, and there were still about 1,400 active cases. KFLA, obviously a much better circumstance. Our per capita testing is as good, if not the best in Ontario, but a total of 106 cases, very few hospitalized, no deaths specifically from KFLA, although we did have a couple of people who passed away in our hospital who were from the Leeds, Grenville, Lanark Public Health Unit. And as of Monday, we only had one active case. So I want to talk a little bit about transmission, and I should have fixed this slide up because I was working on it when I suddenly got pulled away. My apologies. So this is a zoonotic virus. It almost certainly arose from a virus which initially infects bats, and probably bats asymptomatically, may have passed through an intermediate animal like a pangolin, and then popped into humans. And what we know now is this virus is now able to transmit from human to human. And principally that transmission is large droplet. There can be some direct contact, and of course, lots of discussion about small droplets or aerosols, or what would be an airborne transmission route, which I'll suggest to you is, although currently always under debate, is almost certainly not in any way a significant contributor. Some of these other things have all question marks behind them. You know, can you get an infection from a laboratory exposure, from a blood transfusion? Can a mother pass it to a child? These are all unknowns. At the moment, at least, there's only anecdotal evidence, for instance, that there could be transplacental spread. And that can be a little bit confounding because you have to be absolutely sure that that transmission occurred to the child while in utero and not after they were born. So I wanted to talk very specifically about airborne transmission because I have this is really one of the most common questions we get asked, and it pops up with a fair degree of regularity about every 7 to 10 days when a group of aerosol scientists publish a study or an opinion paper typically which says, we think it's airborne, why are the doctors not listening to us? So the bottom line is that there's always the potential for any respiratory virus to be airborne, but this particular virus, that likely happens extraordinarily rarely. And yes, there are anecdotal cases which would implicate that airborne transmission occurs, but it is clearly not the dominant mode of transmission for this virus. The epidemiological evidence really supports that this is a droplet spread infection, because there's no evidence that would suggest it's airborne, and I'll show you that in a second. Problem with this is that we've been facing a lot of, and why I'm going to talk about cognitive bias in a minute, of arguments that are put forward by the proponents of airborne transmission around the precautionary principle, which is where we start off with in any pandemic. They talk about indirect evidence from aerosol research that aerosols exist and they could contain virus. And then oftentimes they'll speculate because they'll say, well, this happens with this virus, so this must happen with COVID-19. Unfortunately, a lot of it is sort of generated by concepts of confirmation bias. And for those of you maybe not familiar, confirmation bias is when you look at and process information which agrees with a thought you already have, and you get rid of things that don't agree with what your maybe perhaps current thinking is. So just to sort of show you the difference is that, you know, we know that measles is an airborne virus. And what's characteristic about measles is you require very little virus to initiate infection. It's associated with some development of a bloodstream infection with the virus, which can then lead to alveolar disease that generates small droplets, which can have a lot of infectious virus in them. And so these lung-derived small respiratory droplets can drive infection. COVID-19, however, is a lot more like a droplet infection. We don't know the ID50 specifically for COVID-19, but it's clearly larger than what we see with things like measles. And we know that this is a disease that has almost no primary viremia, and if there is a viremia that's been detected, it's minimal. And so that you don't get this alveolar disease, therefore you don't generate lots of virus containing small droplets, even if you do aerosolize things from an infected person. And where we see the highest concentration of virus is in these very large respiratory droplets that come from the upper respiratory tract, and those are what tend to transmit the disease more readily. To give you just an example, this is a little graphic that shows you the reproductive number. That is the number of cases that are generated in a susceptible group from an initial case. And the higher that number, the more characteristic it is of airborne infection. So if you look at something like measles or smallpox, which are clearly airborne transmitted infections, you see reproductive numbers as high as 7 to 18. Influenza, which we know is respiratory droplet spread, is certainly not airborne, other than in the most unusual circumstances. It bears a lot of relationship with its reproductive number with COVID-19, which you can see here. So if this was an airborne infection and it was somehow the dominant mode of transmission, we would not be seeing right now what amounts to being about 15 million people on the planet infected. We would be seeing billions of people on the planet infected, and that just has not happened. So when we look at the routes of transmission for COVID-19, what we can say, and I put this up here just to kind of summarize things, is that about 90% of these infections are clearly transmitted through droplet spread, which is you in close contact with someone where there's no barrier protection, and you're within this cloud of large respiratory droplets that everyone has around them simply by breathing and or talking, etc. Fomite spread, which is transmission that occurs through an inanimate object or through your hands, as an example, is about maybe 10%, but we really don't have a firm number on this one. And that's really driven by the fact that we do know other coronaviruses have a fomite transmission speculated about them, the human coronaviruses that cause the common cold. And we know that you can find the virus, sometimes intact, actual viable virus on a surface. Airborne aerosol transmission has got to be less than 1,000, 1 in 1,000 transmission routes, and may even be an order of magnitude lower than that, at about 1 in 10,000 to 1 in 100,000. So that's really what we know from EpiData, and that is really what's telling us where the route of transmission is, and it's why, therefore, wearing a mask and maintaining physical distancing from someone, which helps prevent droplet transmission, and then washing your hands and not touching your face, which helps to prevent fomite transmission, are the principal ways that we prevent people from getting infected with COVID-19. Now, this looks really complicated, but any mathematician will tell you that the guy who wrote this, which is me, doesn't know anything about math, because the units of time, intensity, prevalence over an efficiency rating for a mask and distance from a source creates weird units. But what I made this up to show is that the probability of getting COVID is related to these factors. The longer you're exposed, the more intense that exposure, and the higher the prevalence in your community, the more likely this number goes up. So the numerator gets high and the denominator stays low or doesn't change, so probability goes up. However, if you wear a mask, or you wear a face shield, or you have partitions that are available to reduce droplet spread, and the further you are from the source, then this number becomes big and probability drops. So this number will become smaller. So really the key messages is that this is spread by large respiratory droplets. That's what accounts for about 90% of cases. Fomite transmission, probably about 10% of cases. And then somehow a little tiny bit of aerosol transmission that occurs under unique and unusual circumstances account for rare cases of transmission. So this is not an airborne transmitted virus. Generally speaking, it is a large respiratory droplet spread one. So talk a couple of minutes about vaccines, just because this is the kind of the good news message in what we're facing at the moment. Lots of vaccine development. And what you can see here is that there are lots of vaccine candidates in preclinical trials, and now we have human trials ongoing. There are 3 vaccines that are now entering phase 3. And that's the Moderna vaccine. And I'll just sort of say, this is an American vaccine. The Oxford AstraZeneca one's a British vaccine. And the Sinovac one is actually a Canadian and Chinese vaccine. So that'll be relevant to, questions about when do we get availability. So these are now entering into phase 3 trials. And these are the 3 top contenders. The 2 ones that you see at the top here are adenovirus vector vaccines, and I'll show you what that looks like in a second. The Moderna vaccine is a messenger RNA vaccine, and these are the ones that are really moving forward and look the best, at least at this point in the trials that have been ongoing. It's a little bit more complicated table, but just to show you that here's the Oxford vaccine, here's the Moderna vaccine, and here's the CanSino vaccine, and all of them are in phase 3 or about to enter into phase 3. Data gathering, of course, is going to continue for a while. At the moment, we're looking mostly at healthy adult subjects, just because adults do tend to get the infection more readily than children do, at least children under the age of 10. And so they're going to tell us really what the safety issue is. This week, the Lancet published 2 studies in the same article. This is the Oxford vaccine, and this is the CanSino vaccine. Both of them are recombinant adenovirus vectored vaccines. This uses a chimpanzee adenovirus. This one uses a recombinant adenovirus. And this little schematic is, and hopefully people can see this, is what you do is you introduce a piece of the coronavirus that codes for something you think is going to be a neutralizing antibody, and you put it into a different virus which doesn't replicate well. That's an adenovirus in this case, which has been rendered non-replicant, and you inject that into people. They then create antibodies against this funny little piece that you put in there. Those antibodies then go on to protect the host. So it's an interesting technology. It has been used experimentally. It is not commonly used at the moment for vaccine strategies that we currently have out there. But it's looking very, very favorable. And one of the very interesting things about it is that these vaccines seem to induce not just the production of antibodies, but they actually produce a response in the part of your immune system that will remember this particular antigen and create new antibodies, and that's a memory T cell and B cell response. So very, very exciting. If this pans out to be a safe vaccine, this may be really part of how we get out of this COVID-19 situation. The troublesome thing we have is that it takes many years traditionally to develop a vaccine, and this is just a little schematic about how that typically happens. And what we're doing in an outbreak like this or a pandemic is we're trying to speed this whole process up so that it takes, somewhere under 2 years versus the sort of 10 years that this paradigm does. And a lot of that is requiring coordination between researchers, clinical trialists, and industry, so that when approval occurs, we can actually make a lot of vaccine and get it into people to protect them. I'm going to finish off by talking a little bit about how people respond to pandemics. And I've often joked to people that I've done talks for is that I really should have had training in psychiatry, maybe more so than microbiology and infectious diseases, because during a pandemic, we run into lots of problems. This is just a little diagram to suggest that one of the responses that happens when a pandemic like COVID-19 hits is initially there's a lot of fear, and it takes a while to get out of that and then into a sort of learning zone. And I think maybe what generated some interest in attending this session that UHKF has put on today is that you're in this zone now and you want to learn about stuff that's going to help you sort of think about this this whole new problem in a different way, and then ultimately to grow into where you need to be able to continue to live your existence during a pandemic. And part of this, the difficulty with this is that our first response typically to any kind of stress is to activate the more primitive part of our brain, the limbic system, which is, it's always got thrown in lizard, a big Star Trek fan, so I had to throw the Gorn here, fighting Captain Kirk. And that emotional side of our thinking relies very heavily on stories and anecdotes and personal experiences, and not sort of the thinking processes you need. Remember that journalists tend to write stories, and those stories can kind of tug at your emotions and continue you in that point. And I would suggest that even doctors, who we are traditionally driven by science and hypothesis and rationality, we're very easily swayed by pressures of a crisis like this. And our emotional reactions, therefore, can sometimes impede our ability to do our jobs effectively. So one of the things that humans do is we have heuristic thinking. Some of you, just so if you don't know what a heuristic is, it's a self-taught shortcut to problem solving that uses a very simple method that isn't always optimal or rational, because you want to come up with something that fixes everything quick. So it's a thing that you use to get to an immediate short-term goal to relieve stress, anxiety, and fear. But unfortunately, it's not, doesn't do us well when we're trying to get things going. One of the things that Heather and I have faced is, in fact, talking with our healthcare worker colleagues about, this is not an airborne transmitted infection. Therefore, you don't need an N95 respirator. You just need a regular procedure or surgical mask. Because it was much easier to think, I'm just going to not worry about the science. I'm just going to wear an N95 all the time. And N95s are in short supply. So there's lots of cognitive bias that comes into heuristics. I already mentioned confirmation bias to you, but we do have things like anchoring bias, where you shortchange your decision-making process. So although I used a medical example here of perhaps someone thinking about 3 negative tests on a patient saying, I'm sure that's what they have. The other thing that comes up with lay people is, you have a cold, you've got tested, but you're still convinced you have COVID-19. So you keep going for tests and you do things that you shouldn't do. And then the other thing that humans do a lot is availability bias, which is to favor recently acquired information because it's easier to recall than older information that you may have heard about. And so there's lots of predictable behaviors that arise as a consequence of cognitive bias and heuristics. One is denial, and we're certainly seeing a lot of that popping up now around the issue of mask wearing. Denial can be fed a lot by other heuristics you have, and you may be ideologically bent to the idea that somehow masks are infringing on some other right that you have, without recognizing that it's a good altruistic behavior to protect yourself and protect others. We also know that humans like to control their immediate environment. I think everybody's familiar with the rush on toilet paper back in January, February, and March, and then more recently in the last few months for masks. And that is because we like to maintain control because we feel it gives us a sense of security. Unfortunately, that may be a false sense of security. And of course, even though I just told you how good news vaccines are, people are always wanting to hear good news, but be careful, because good news can also make you do things like we're seeing now. So we have young people saying, well, the virus is under control. Oh, they're relaxing social distancing issues. I can go to a bar, a restaurant, a dance club. I can hang out with my friends. And of course, what we're seeing with that now is that there's been an increase, and is an increase happening in young adults with COVID-19. We know that fear, as sort of generated in this curve, will cause people to isolate themselves. So the number of people circulating drops, people self-isolate, the virus happens and it starts to peter off. As it diminishes, people stop isolating, they come back out of isolation, and then what do you get? You get a second wave. And second waves are what we always are, and subsequent waves are what we're worried about. So when we look at reopening, it's a bit like this Charlie Brown Lucy scenario where it looks very inviting to kick that football to reopen, but we all know what happens when Charlie Brown runs up to the football and Lucy pulls it away. So lots of concerns here. Herd immunity, which has to be at least 60% of the population, and perhaps ideally somewhere near over 80%. What we've seen in jurisdictions like New York and Madrid, even in Wuhan, China, and others, is that even when you have widespread infection, you're not getting there very quickly. And I think we have to be very careful about trying to assume that herd immunity is going to be our protection. I think I'm much more optimistic about vaccine. Lots of projections here that have come out of a group at Harvard, which look at things like how long does immunity last, whether there's something called seasonal forcing or seasonal variation where it's more common in winter than other times. And it creates all these different graphs. The gray lines here represent things. I'll tell you that scenario D, which is the elimination of the virus because everybody gets lifelong immunity, is not a scenario we're looking at. I think right now we're probably looking at either severe wintertime outbreaks or perhaps outbreaks every couple of years as the main models right now that are driving where we're heading with things. So my take-home messages is we've been very fortunate here in Southeastern Ontario and Kingston. We've emerged from a first wave with a few cases, but we have to be careful because there are a lot more susceptible to a second wave because we have lots of people who weren't infected. Remember that it's a large respiratory droplet spread infection. Airborne transmission is very rare if it occurs at all, and those are based on anecdotes. And recognize that the psychology of fear sometimes overcomes rational thinking. And that's actually, I think, been one of the most challenging aspects that Heather and I have faced in terms of infection prevention and control at our hospitals here in Kingston. And the good news, some vaccine candidates are progressing quickly through trials. And we may be at a point that this time next year, there may be vaccine available and getting put into people's arms to protect us and let us get moving forward with a more normal setup. So these are my little quick take-home messages, but Heather's going to expand a little bit on this because I think this is the message we've been driving to people, and mostly importantly, be kind. You guys are all charitable donors, so be kind is probably your natural motivation, but it isn't, unfortunately, for some parts of the planet. So I'm going to stop my sharing there and turn it over to Heather to continue.
Okay, I'm just going to share my screen here. There we go. So thank you, Gerald. So today I'm going to talk a bit about some of the key learnings from an IPAC perspective as we've moved through this COVID-19 pandemic and how it's affected hospital operations. First, I'm going to talk about our preparedness levels, and then the other 5 S's are around supplies and stewardship, surveillance, staffing, and how do we sustain all this. So firstly, you know, infection control and infectious disease specialists are quite accustomed to dealing with emerging infectious diseases and pandemics in general. You know, we've gone through things like SARS, MERS-CoV, Ebola, and H1N1. An interesting side story, I actually started at Kingston Health Sciences Center in Prop Care on January 6th, which happened to be the same day that the World Health Organization released their first technical bulletin saying that there is a severe pneumonia coming out of Wuhan, China. So I had sort of just met Gerald and met the team, and immediately we all sort of jumped into action at this point, guardedly jumped into action. So from the times of Ebola, when that was happening a few years back, the Ministry of Health required that hospitals do something called an organizational risk assessment for infectious diseases, and that should be done annually. So that's something we undertook back in January and February to make sure that the organization was well prepared. And that's very much built upon the hierarchy of controls, which is a way of reviewing hazards within the workplace and making sure that there's controls around those. So the way we reviewed hospital operations was by looking at how do we eliminate COVID-19. So we know we can't eliminate it because people have to come into the hospital for care. So looking at substitution, can we get people to work from home? Is that a possibility? Can we do virtual visits for patients? So these are some of the big changes that have happened as a result of COVID-19. We looked at engineering controls across our whole hospital, and Gerald talked about a bit of this previously around people thinking it was airborne originally. We've since learned an awful lot, and that we know that it is droplet contact at this time. But nonetheless, early days, we reviewed infrastructure around the hospital to make sure that we could safely, from an infrastructure perspective, manage patients through the system. So making sure all our airborne isolation rooms are working, we have plexiglass up and partitions and things, and separation between patients and staff to make sure we can protect everyone. Early days, we really went on a road show between the IPAC team and with Gerald in occupational health and safety, making sure that we really ramped up awareness so people knew that we were doing this preparedness, and that this is a potential that we could have a pandemic. I remember going to a meeting with Gerald, and he actually said at one of our IPAC committee meetings that this could potentially be worse than SARS, and it's probably the biggest understatement of the century. But anyway, the next thing we reviewed is our administrative controls, and what do we have in place as far as policies, procedures, and making sure that we're keeping people safe through proper workflows. And finally was an intense review of our personal protective equipment as an organization. Shortly after Infection Control and Occupational Health and Safety undertook this organizational risk assessment, things were moving quite rapidly, and incident command was struck, which is actually part of the incident management structure. So this is a way in which you manage emergencies within an organization, which involves specific key stakeholders across the organization so that you can make quick decisions in cases of emergency. So that's really helped mobilize our hospital and ensuring that we remain prepared and sustain that preparedness. Some of the big things, I'll give you some of the background around what we've been experiencing and some of the learnings. So when I first started, right away I met with the emergency preparedness director to get an understanding of what our pandemic supply looked like. I was very happy to see that actually KHSC has done a wonderful job, and Providence Care as well, in managing and keeping up with their pandemic supply. So they had a very robust stock of personal protective equipment to keep staff safe, and had stockpiled approximately 4 to 6 weeks worth of personal protective equipment, which originally is what the ministry had required hospitals to do. Many hospitals have actually let that pandemic supply lapse, so we were very well positioned going into the pandemic. Little did we know, however, that COVID-19 was going to be with us for months, not weeks. So while we did have a lot and still continue to have a decent amount of personal protective equipment for our staff, it is something in future that is a key learning. How much PPE do we actually need based on what we're looking at? Interestingly, early days, we quickly ran into a swab shortage. The swabs are called Copan swabs, and they're actually created in a factory in Italy, in the epicenter of where they had their COVID outbreak. And so there was immediately a swab shortage because they shut up the plant, and they were not able to make swabs. So we had to switch gears and find other swabs in order to test patients and staff. We ran into disinfectant shortages as well as hand sanitizer shortages, and we were able to partner with Queens in order to get some hand sanitizer. We received a tremendous amount of donations, whether it's disinfectants or personal protective equipment from the community, as well as organizations within the community in the region. So couldn't believe actually the amount of donations that we received for personal protective equipment and hand sanitizer. However, all that product actually needs to be reviewed. So the donations were great, but we actually needed to review all of it and make sure that it was appropriate for the front line. So we quickly seconded somebody from the laboratory who had training in infection control, and they reviewed all these products, and they partnered with our supply chain company 3SO to make sure that these were appropriate products to use with staff. We created a personal protective equipment dashboard as well, so staff had a really good control or understanding rather of how much personal protective equipment we were actually burning through on a weekly basis. We actually doubled our burn rate for masks quite quickly. So, and even now with universal masking, previously we were using about 60,000 masks in a month. Now we're using about 120,000 masks in a month. So a lot of personal protective equipment use, and managing that and staying on that. New terminology has really come out of this experience. So infection control practitioners are trained that all items that are used as far as personal protective equipment really are single use. You use them once and you toss them. You don't wear them between patients. With the supply chain issues that we've experienced nationally and globally around personal protective equipment, we really had to sit and reflect about what pieces of equipment can we safely either extend the use of or reuse. Completely new terminology for us. And then really apply some science to that. So, personal protective equipment, we had to break it down. What is protection for the staff member and what is protection for the patient? So previously, we would never see someone walking through the hallways with a mask and a face shield on, potentially. Now we've introduced something called extended use, where you can actually wear that, because it's for the protection of the wearer. It's not actually there to protect the patient necessarily. So you can wear that in between patients because it's not touching the patient. However, gown and gloves still need to be changed, of course, in between every single patient interaction. We've introduced universal masking within our organization for everyone who comes in the facility. So that's been a big shift, new terminology, universal use of masking. Early days, we started, even before the ministry had put out the requirement to collect personal protective equipment, we saw the writing on the wall, and we knew that there was definite supply chain issues as it relates to masks in particular. So we started collecting masks and eye protection, and working very closely with the Occupational Health and Safety Department, IPAC, and other stakeholders around the organization, specifically which includes the Medical Device Reprocessing Department, to see if we can safely reprocess our PPE if we got to that position. Thankfully, I'm able to report that we have not got to the position where we've had to deploy reprocessed PPE, but it is something that we planned for early days and did an awful lot of testing around. As well, the Ministry of Health has put forth a model for reprocessing N95 respirators. You probably heard on the news, 3M is no longer manufacturing specific respirators, and there are shortages of respirators. So the way this model is being set up by the province is there'll be specific hub. It's going to be a hub and spoke model. And what that means is hubs around the province, specific hospitals have been brought on board to get involved in a partnership with the province where we would potentially reprocess N95 respirators, and spoke hospitals or healthcare facilities would send us their N95s, and then we would reprocess them. So early days, when we were tinkering around and figuring out if we could reprocess PPE, we actually used our Steris V-Pro, which is actually, it's a vaporized hydrogen peroxide machine used to sterilize cystoscopes and other types of scopes. And we put our N95s through that process and had very favorable results. And then after all that experimentation, 3M came out and said that we, in fact, could use Steris V-Pros to reprocess N95. So we'd done all the background work on that, and then they came out with that, which is wonderful. We have since, we're looking at bringing on a machine that has been approved through Health Canada, and we've been partnering with the National Research Council of Canada to reprocess N95s using a machine that has been approved, and all the other hospital hubs would use that machine as well. So that is in the works. Once those N95s are reprocessed at each hub, they'll then be sent back to the provincial inventory warehouse where they would be distributed from that point. So this is overarching what is happening in the background, and it's still in the works, but this is what the model would look like if we go forward with this. So far, so good. We have not had to move forward with reprocessing of any PPE thus far. As far as surveillance is really, it's detective work. Early days, we weren't doing a tremendous amount of swabbing for COVID-19, but that rapidly changed. And even in the most recent months, with requiring swabbing for people even going into long-term care for visitations and whatnot, we're seeing an awful uptick, a very good uptick rather in swabbing. So from an IPAC lens, we really are searching for COVID, and we do that in two ways. In the first way, we do something called sentinel surveillance. And we're actually actively asking patients and reviewing particular risk factors that patients might have. And in absence of symptoms, we'll still swab you. And that's essentially to cast a nice wide net to see if we can pick up people who potentially have COVID. The other way is we do passive and active surveillance. So passive surveillance is just essentially putting up signage, asking people to report if they have symptoms. And active surveillance is actively going to those patients and asking if they have symptoms, and then we will swab you based on your symptoms. So for active surveillance, every single person in our hospital who is admitted is asked 2 times a day if they potentially have a subset of symptoms that would then prompt a swab. So we do, on average, we're swabbing anywhere between 30 and 40 inpatients any given day, and symptoms can be very atypical and minor, and you'll still get a swab. So we have a very low threshold for swabbing, which is very good from a surveillance perspective. Finally, around staffing. So this has been probably the key learning for us, actually, as an IPAC department, is partner early and quickly with the communications department. there has been a tremendous amount of change. Daily guidelines are changing, evidence is changing. We're running out of supplies because of global shortages, and we have to make quick decisions based on evidence, and we have to get people to trust us. And they have to know we're doing the right thing. So we quickly partnered with our communications department, and they were able to help brand our department so that, you know, when people receive an email from the IPAC department, it's familiar, you know that it's from us and you can trust it, as well as the incident command notifications that go out daily. Fantastic collaboration with communications and getting on social media and making sure people know we're a trusted source, and we're doing this from a place of science and the best evidence and in their best interest. Big learning for us. The next piece is around just sustaining all of this. We really are finding staff are fatigued. The IPAC department has been working around the clock. Other departments, same situation, administration as well. Really there is, you know, there's fatigue, there's PPE burnout, having to wear your mask all day long. People are getting frustrated, and just supporting staff where possible, making sure people take vacations and that sort of thing. We are in the process of putting through or reviewing projections for PPE and staffing. That's ongoing, of course, and things fluctuate based on our policy changes as well. We're partnering with, actually with KFLA Public Health, and you've probably heard this from some other regions, where they're creating these strike teams or almost SWAT teams that go into long-term care that are experiencing outbreaks. So we'll be looking at doing a similar model if we ever are up against a situation where we might have long-term care and outbreaks. Planning is ongoing, and all of this is managed through the incident command structure, where we look at surge capacity, workflows, field hospitals, beds and vents, and what we're looking at organizationally. Our assessment center has been running successfully for some period of time now. They're averaging 200 swabs a day. Back in May, they had about 1,500 swabs for the month. In June, that jumped up to almost 6,000 swabs in a month due to the long-term care opening up for visitation and people getting swabbed asymptomatically so they can visit, but also due to the nail salon outbreak that occurred in the KFLA area. So big kudos to our risk assessment center, and that's managed and directed under the direction of Cindy Bolton, who's just been incredible in her leadership with the assessment center, which is exclusively run by KHSC now. It was previously a partnership with KFLA, but they had to deploy a lot of their staff out to help contact tracing in the Toronto area. So essentially the learnings that we can take away from this is that preparedness, it's ongoing. It fluctuates up and down, but we always remain on high alert and making sure we're on top of all the best evidence as well. Supplies, I feel like moving forward, there'll be big changes for supply chain. Shortages of this degree were certainly not anticipated, and I think, you know, in future this is something we'll have to review, you know, nationally, and how this is how personal protective equipment is manufactured and where we get it from. Stewardship. We've had to make some tough decisions, and who gets certain pieces of equipment and who doesn't, whether it's disinfectants, hand hygiene, and that sort of thing. So being able to be nimble and quickly react and get things to the people that need it in the front line. Surveillance is ongoing detective work. So making sure that we have a very low threshold for swabbing and always looking, and preparing, making sure we're prepared for clusters and outbreaks and quarantine and that sort of thing. Staffing, just making sure that there is change fatigue. People are sick of constant changing messaging, but just ensuring that they know that they can trust us, and we're coming from a place of good, and trying to keep everyone safe. And just ongoing sustaining this is really the incident command structure that from the emergency management perspective of KHSC has been incredible in really helping us be nimble in managing this entire situation. And it's everyone's really been working around the clock. So I will wrap it up at that, and I believe we will be taking questions. And I just want to thank everyone for their attention.
Yes, we did have a couple of questions that Dr. Evans answered live. There we go.
I'm happy. I can actually, if somebody wants some sort of verbal backup for those ones. Oh, the host has stopped my video. You can't see me anymore.
Oh, hang on.
So the last one was just about long-term care. There you go. Long-term care. The reason we really did well in long-term care is because our community prevalence was so low. When community prevalence is higher, it always finds a way of sneaking into long-term care. The best example is what happened in Sweden. Many people know that Sweden had a very different approach early on. They were trying to protect long-term care homes, but they were going to allow the virus to kind of circulate a bit in the community, hoping that that would generate more immune people in the population. And of course, it didn't work. Once you had community spread in Sweden, it got into the long-term care homes. And so one of the ways we protect long-term care is to protect our community in general, and then that will reduce that transmission event. I have to say, though, if you start your social distancing measures early, and we started it here in Kingston really before we got our first case, and when you have a jump on the start of it, you have much better controls in general. And part of those controls also involved, unfortunately, restricting visitation at long-term care homes, and then public health has been working to try and improve IPAC measures in long-term care. I think it's important for most people to understand that, you know, with the resources that Heather and I have in the hospitals, we can do a lot of really good high-level evidence-based infection prevention control. Long-term care institutions are very much challenged by the availability of a full-time person to do IPAC. I mean, Heather does IPAC full-time as our director, and then she can call on me. And right now I've been doing it almost full-time since this whole thing started. But essentially, long-term care homes don't have that same benefit. And so there's a lot of education and stuff that has to go on to make sure that IPAC measures in long-term care are better than they used to be. And hopefully you'd love to have it at the same level we have in the hospitals, but that can be a challenge just because of resources. And long-term care homes, some of them are, of course, funded in a very different way than our hospitals are.
There's a few more questions there, Dr. Evans, now, I think mostly for you. One is concerning school coming and children and their risk with COVID. Is there a concern around that?
Well, this is going to be our next big challenge, and certainly I've been publicly talking about how we should be devoting our energies to how we're going to bring kids back to school and stuff. There's some interesting biological things that happen with kids. Everyone is familiar with the fact that children don't tend to get as severe a disease as adults do, so the impact of that infection is less in children. But we also have some tantalizing evidence, both epidemiologically and biologically, that kids may get this infection a little less readily than adults do. Kids can definitely get infected. Whenever I say that first line before that, everybody goes, oh, kids don't get infected. No, but they don't get infected at the same rate or frequency that adults do. And that may be because we have data that suggests that the receptor on cells that allows the virus to attach to a human host and infect it is expressed a lot less in small children under age 10 than it is in adolescents and adults, and older adults in particular. But the other thing we know epidemiologically from some good contact tracing in South Korea, looking at over 75,000 people, is that the group with the lowest attack rate are kids. And so that sort of fits with what we know biologically. So it may be, it's still going to be a huge challenge because yes, there are children in schools, but there's also lots of adults in schools. And so there's always the potential that schools could act as a vehicle to generate, of course, more problems with second waves. So it is not an easy solution. If we were going to be throwing taxpayer dollars out, I would say we should be throwing them at funding for schools to be able to open during the pandemic, which is going to mean a lot more custodial staff, a lot more bus drivers, a lot more support staff. And all of those will be useful to protect the children and to protect the teachers who are in the classroom who are teaching them. Elementary school, probably going to be a little easier than secondary school. And certainly post-secondary stuff. So yeah, we're getting there, and I think we should be able to do it, but it's going to require a lot of time investment and other things to be able to make that happen. I guess the next question is, do I have concerns about new viruses arising in China? I always have concerns about new viruses arising. Zoonotic transmission viruses are really becoming the norm. Ebola from bats, original SARS was from bats, MERS was from camels. There are tons and tons of other viruses, not just coronaviruses, but avian flu viruses and others that are just waiting to emerge into the globe. And, you know, just as a reminder not to diminish everybody's sort of existential thought processes, but humans have really only dominated the earth for a few thousand years. and nature has a way of eliminating species that overpopulate themselves, and this is one of the ways it happens. So if you don't know about Charles Darwin and his law of natural selection, this is probably a little bit of it in action. So I'm always concerned about this happening. And I think, you know, the nightmare scenario is we're trying to get out of COVID-19 and suddenly an avian flu hits. It would be extraordinarily challenging. At that point, Heather and I might retire. I don't know. I won't speak for Heather. I might retire. Am I free to share any background information on the nail salon outbreak? I actually had a slide to show you guys that. So the nail salon outbreak really was essentially that there were staff that were working at a nail salon. They were unwell. They were still going to work. So we have a big rule nowadays: if you're sick, you don't go to work. And they were going to work. And so that resulted in transmission to clients. We also learned that there's a lot of interconnectedness between the nail salon operators here in Kingston. A lot of them work at more than one salon. And so that ended up creating problems with transmission that was occurring in other jurisdictions. And then I can tell you, generally speaking, public health went into the nail salons around the city and found that they weren't necessarily really carefully adhering to infection control measures that should have been in place. And so that allowed, obviously, an infected person who was sick to end up transmitting it to others. And so it's exactly what you would expect when people slack off on the social distancing. One of the social distancing measures is if you're sick, you don't go to work. And then if you're not following all the rules and you overcrowd a nail salon with lots of customers because you want to fill it up, that's what's going to happen. And so that's essentially most of the issue that happened with that particular outbreak. Oh, I don't have data about postal code things here in Kingston. The numbers are so small that I don't know that it would be particularly relevant. It has been relevant in large cities. In large cities, of course, we clearly recognize that health issues always are often tied to issues around socioeconomic deprivation, and that's certainly been shown when you look around Toronto and any other very large urban center in the Western world. So it's why we still continue to need to pay a lot of attention to correcting those kinds of disparities that occur in our society in general. The good news in Canada is that because of our socialized health system, it's a little bit less impactful, but it still pops up here as well. Somebody wants to know if there are cases. If there are cases in your apartment building, don't worry. This is not spread through the water system, the sewage system, or anything else. You know, be careful when you're out. If your apartment building should be having protocols now to increase cleaning in common areas, mail rooms, and elevators and things like that. And take some hand sanitizer around with you. If you're touching surfaces like elevator buttons, wash your hands afterwards. Don't go touching your face.
Okay, thank you, Dr. Evans and Heather. I think that's about all the time we have now. It is noon, so we need to be respectful of people's time. I think I'll turn it back over to Tom to say a few closing remarks.
Thank you, Gerald and Heather, for taking the time to join us today and sharing your knowledge. The more we all know about this disease, the better informed we are to make smart decisions about how to help stop the spread. To all of you in the audience, a big thank you for joining us today. I hope you found the presentation interesting and it was easy to participate. This has been a time of change for all of us, and I'd like to thank you all for your outstanding support, particularly over the last few months. Members of the community, like you, have continued to support the hospitals throughout the pandemic, and the volume of gifts received is impressive. In addition to cash gifts, messages of support and in-kind gifts such as PPE, gift cards, and personal care products in support of healthcare workers have been overwhelming. Seeing the blue healthcare heroes' hearts displayed in windows all over town is truly heartwarming and makes me very proud to be a Kingston resident. Thank you for continuing your support. You are the reason that our healthcare teams have been able to minimize the effects of this pandemic in our community. Please take a few moments to complete our survey, as this was our first go at doing this virtually and would be invaluable for us to hear about what your thoughts are, so we can ensure that this continues and that we can provide you with the types of speakers you want to hear. Thanks again for joining us today. Hope we'll be able to see each other face to face in the near future. And so in closing, thanks much, and make sure you have a safe and enjoyable day.